Good evening, viewers. You're welcome to the Instagram Live program today. As you may be aware, June is Infertility Awareness Month, and at ProCare Hospital, we're very passionate about infertility, and so we thought to host this IG Live to help people understand infertility, to answer questions that may be troubling to people. So once again, I'm Dr. Moses Fache, a consultant obstetrician gynecologist and a fertility specialist at ProCare Hospital. So I would just wait for you to send in your question. We already have some questions sent in, via DM. So we would start addressing some of those questions while we probably wait to take some live questions. You're welcome once again.
Okay, thank you, sir. All right, so we have some questions already. So we'll start with the questions we have. The first one says, I have an ovarian cyst, which I have done the surgery twice, but it keeps occurring, but I don't know why. Doctor, please.
All right, so that's a patient who said she has had ovarian cyst twice. She has had surgery done twice and it keeps reoccurring, and she would like to know why. Ovarian cysts, depending, there are so many varieties of ovarian cysts. Some of them are functional, meaning that they occur as part of the normal menstrual cycle. And most of the time, those do not need surgery. They tend to resolve on their own. And they can also actually reoccur as long as you are menstruating, you are within the reproductive years, having a functional cyst, and does not mean you're not going to have another one. So that's one of the reasons we are not even quick to want to operate on them. However, there are some pathological ovarian cysts, like endometriotic cysts, for instance, which can also reoccur even if you've had the surgery. So that patient will need to be reevaluated to determine the kind of cyst she's having, and also to be sure that she's actually having ovarian cystectomy. Sometimes people are told that they have ovarian cyst surgery, but in essence, what they have done is just like drainage of the cyst. And so the cyst wall has not been removed. So I'm unable to determine the extent of the surgery she has had twice, and it would be nice to get evaluated, to see the extent of surgery that she has had and the type of ovarian cyst that she has had. Some of these ovarian cysts can be managed medically, meaning that there could be medical means to prevent the reoccurrence of the cyst. But until that evaluation is done and it is clearly understood the kind of ovarian cyst she has, it will be difficult to to say that it will not reoccur anymore. So next question.
Okay. Good evening, doctor. Please, my question is, what's the cause of IUI failure twice when tubes are not blocked and ovulation occurred? Please, I will need more clarification.
All right. That question says this patient has had IUI twice, and on two occasions they were unsuccessful. And she says her tubes are open and she ovulated. So she wants to know the cause of the failure. So I would quickly try to explain what it takes for a natural conception to occur, and then also dive into what IUI means. IUI stands for intrauterine insemination, and it's one of the fertility treatment options. It's like a middle ground between ovulation induction, and then you have intrauterine insemination. Then IVF is at the top on the other side. So for natural conception to occur, I'm going to use this model. The model you're seeing here has the uterus, which of course is like this, but this is the full uterus. That's the womb. And then you have one ovary here and the other ovary here. You have the tubes. So usually in the beginning of the menstrual cycle, the hormones from the brain begins to act on the ovaries and then make the ovaries to produce, to begin to, the follicles in the ovaries now to begin to mature. As they are maturing, those follicles are what contains the egg. They are also secreting hormones that works on the lining of the womb here to make it habitable for a fertilized egg, which is, called embryo at the time it arrives in the uterine cavity. So when this egg eventually is released, which is what we call ovulation, it has to enter the tube, and then there is, of course, expectedly sperm that is coming from here, which is deposited in the vagina. This is the vagina. And the sperm cells will have to swim through the cervix, go into the uterine cavity, enter the tube, and then meet with the egg, usually in the widest portion of the tube, which we call the ampullary portion. And that is where fertilization usually occurs. So this fertilized egg will now begin to travel back and then settle down within the uterus. Now, any defects in these processes would not allow pregnancy to occur. So it's either that the ovary did not produce eggs, or the egg that is produced by the ovary did not enter the tube. Sometimes the egg would enter the tube. Maybe there is no sperm, or the sperm enters the tube. It is not every time that egg and sperm comes together that there is fertilization. So you can have failure of fertilization, and in some cases you can actually have fertilization and the egg travels back and it does not settle. Maybe the uterine cavity is not habitable, and so it does not settle down. There are occasional instances where the fertilization, there may be implantation, but it gets washed out before even the person misses her period. That's what we call chemical pregnancy. So what IUI does basically in trying insemination is in trying to augment this process. Basically, is depositing the sperm using a catheter like this, such as, to deposit the sperm here instead of the sperm deposited in the vagina during intercourse. So what it has done is it has shortened the distance that the sperm would have to move, and then it also have bypassed being able to cross the obstacle of the cervical mucus here. So the sperm is deposited here usually after treatment, and so it is expected that the egg that is released here, either because in a natural cycle where no medication has been used to induce ovulation, or in a medicated cycle where ovulation has been induced using medication. So it is expected that the egg will enter the tube, and so the sperm that is deposited here would be able to get to the egg faster. However, as you would see, that is all that IUI can do, to deposit the sperm closer to where it needs to be, and then to give medication to facilitate egg release. It does not it cannot influence the destination of these eggs. So if the egg is released and it does not enter the tube, the woman cannot get pregnant. If the egg enters the tube and it meets with the sperm and there is no fertilization, then there cannot be pregnancy. If there is fertilization and there is something wrong with the womb, then the embryo cannot implant, and if there is no implantation, there is no pregnancy. So it makes sense to know that one of the fundamental requirements for IUI, and as such ovulation induction as well, is that at least one of the tubes must be open, which of course the woman has said that her 2 tubes are open. It means that she had done tests that shows that the 2 tubes are open, and so at least 1 tube must be open. And so the maximum success you can actually have from IUI is about 20% in one cycle of IUI. So it means that there are some other factors. It's not just to release the egg. So if this egg does not come into the tube, or it gets into the tube and there's no fertilization, or there is something wrong with the womb, maybe there are scar tissues in the womb, maybe there are fibroids in the womb, maybe there is a congenital abnormality or like septum in the womb, then it may not be habitable to accommodate a fertilized embryo. So further evaluation may need to be done. And of course, you know that when you do this treatment, you may need to do them up to 3 to 6 cycles before you give up on them. And that's because of these other aspects of the process that we cannot influence. So the fact that 2 cycles have failed does not mean that the third or fourth cycle may not be successful. So if all these evaluations have been done and we are sure that the womb is fine, the tubes are actually okay, we may also look at the protocol. How is this IUI? How is the ovulation process being done? Because sometimes the drugs that are used to induce ovulation may have adverse effect on the lining of the womb. This is particularly true with the common drug clomiphene, that even though it's helping to release, to produce, to cause ovulation, it has some detrimental effect on the lining of the womb, as it does not allow the lining to get as thick as may be required. So these are some of the aspects that will need to be looked at to be sure that everything is on point. And then if that is done, then I think there should be success in the horizon. Thank you.
Thank you, sir. Please, sir, I had a miscarriage since March. Up to now, I haven't seen my period.
Okay, that person has a miscarriage. She had a miscarriage in March. March is about 3 months ago. And she hadn't seen her period, and she's concerned. It is typical. First of all, we need to understand what was the pattern of her period before the pregnancy that eventually led to the miscarriage. That is one of the things first. If she has regular period, then we'll expect that usually within a period of 6 weeks after a miscarriage, she should at least have seen one period. If she has not seen a period, then we need to also look at the fact that if she had any procedure, I mean, most people who have evacuation may need, who had miscarriage, they need to have, evacuation to clean out the womb of retained products of pregnancy, of conception. And some of those procedures, depending on how well they are done or how badly they are done, and the patient's response healing processes, there may be scar tissue within the uterus that may prevent the formation of menses. So I think 3 months is a long time that menses has not come. She would need to be evaluated to be sure that one, the lining of the womb is not damaged, or the outlet of the womb, what we call the cervical stenosis, which can also follow. Sometimes it can be from the procedure, sometimes it can be from infection. And so when you do a scan, you can see that, okay, she's actually forming menstrual blood, but it is accumulating inside the womb, what we call hematometry. So she has accumulation of menstrual blood inside her womb. So an ultrasound would be necessary to determine whether or not there is accumulation. If there is no accumulation, we will need to measure the thickness of the lining of the womb. And then, of course, so apparently she needs to be evaluated again to determine the reason why she has not seen her period 3 months after a miscarriage.
I need your help. I need your help, sir. Please, I thought I was pregnant last month, but this month I started seeing my period. I went to the hospital and the doctor said I have an infection. They ran some tests on me and gave me the drugs, but still my period is not fast.
The question is a bit ambiguous in terms of, period. Initially, said period, didn't come, so she thought she was pregnant. And it was confirmed apparently that she wasn't pregnant. And she had seen a doctor who had given her some treatment. Now, she says the period is not fast. That sounds a bit ambiguous because I cannot relate what fast period would mean. And I think I would suggest that, okay, if you're already seeing a doctor, then you should speak with the doctor to let her know the characteristics of this particular period that you are seeing, so at least he or she would know the next thing to do. All right.
Okay, thank you, sir. Okay, so another question is, what is endometriosis?
All right. So I think I would attempt to just explain briefly what endometriosis means. But then, if you're one of our followers or if you're going to be joining, I think we have a whole session on endometriosis in one of our Instagram live previously. So I will advise that you go back to that video on our page, and then you would have a better understanding of what endometriosis is. But briefly, endometriosis, this is another model of the womb, of the pelvic structure, the uterus. This time, what you saw earlier was clear because there is no disease. This is showing different diseases that can affect the womb. And so you're seeing some black deposits here. So these black deposits that you're seeing around represents tissues that are similar to the inner lining of the womb, which we call endometrium. So endometriosis derives its name from endometrium, which is the inner lining of the womb. When you find such tissues outside of the inner lining of the womb, it is called endometriosis. And so as you can see, it affects many parts of the pelvis, the vagina, the back of the womb, the womb itself. It affects the ovary, can cause endometrioma, that's ovarian cyst. I mentioned that earlier. You can see it on the tube. And so it's a very devastating disease. You can see here that it affects the muscle of the womb. And in this case, when it affects the muscle of the uterus, we call it adenomyosis. Because they are in the same environment. It's just that like you have shifted from where you're supposed to be into the next zone, and so it gives rise to what we call adenomyosis, which is so it's adenomyosis and endometriosis are similar conditions. It's just their location that makes them differently, and so it causes significant pelvic inflammation every time that the woman is menstruating. It's like there is fire in her pelvis. One of the most common causes of pelvic pain, chronic pelvic pain, and it's very debilitating, makes people absent from school, absent from work, because unfortunately it affects women of reproductive age, and so it reduces significantly their quality of life. It is such a condition that affects fertility because not only does it damages the pelvic structures like the tube, it can cause tuber blockage. If it causes adenomyosis, it makes implantation difficult. It causes ovarian cysts like endometrioma, which may require repeated surgeries. Like the first person who says she has had 2 surgeries, it could be endometrioma for all you care. Now, this is a condition that damages the reproductive structures. We do not know the cause, and so there is no cure, so to say. Most of the management modalities would also not allow the woman. Most of the things that we use to suppress endometriosis would not allow the woman to conceive. So this is where the challenge actually is. Because somebody has a condition that is going to damage her reproductive organ. And treating this condition will require medications or methods such as use of Mirena, for instance, that will not allow her to get pregnant naturally. So it is a very difficult condition. And so you require experts, people who have interest in endometriosis, not just any doctor, not just any gynecologist, as it were. Even as a gynecologist, you must delve into the understanding of endometriosis and be passionate about treating endometriosis to be able to know what current modalities are available, to treat this condition. Thank you.
Thank you, sir. Another question is, what's really the main cause of varicocele?
Varicocele is a condition that you find in the male scrotum, the vein that surrounds the testis and supplies the testis, when it gets enlarged and engorged, then it's called varicocele. I mean, simply, there are varicose veins that we see mostly on people's legs. You see an enlarged vein on their legs. So that kind of vein, when you have the veins around the testis getting enlarged and engorged like that, they are called varicocele. And one of the things we have seen is that engorgement eventually leads to an increase in temperature around the scrotum. And that increase in temperature is thought to affect the way that the testis performs its function of sperm production, and so may lead to defective sperm, may affect sperm motility. And so it's one of the conditions that is commonly associated with male infertility or sperm abnormalities. And so when you have varicocele, you will need to be evaluated by urologists. Urologists are the male counterparts of gynecologists who attend to men, and then try to evaluate first if this varicocele, not every varicocele that needs attention, but if they determine that the varicocele is large enough and is problematic, possibly contributing or the main cause of the sperm abnormalities, then they would have to treat it. They have surgical treatment, which is called varicocelectomy, and then there is a radiological treatment, which is called embolization. So any of these methods, are okay to treat varicocele.
Okay, thank you, sir. So I have PCOS and I'm not ovulating naturally. I have had ovulation induction 4 times and I'm yet to conceive.
All right, so polycystic ovary syndrome, which is PCOS, is the case in this question. And it's another very common condition among women of reproductive reproductive age. And there are three main criteria that is used to define those who have polycystic ovary syndrome. The first of them is that the woman have irregular periods, which is as a result of irregular ovulation. That's the first criteria. So if a woman skipping her periods in a month in between, it may be because she's not ovulating regularly. The second criteria is that the woman have features that suggest that she has excess of male hormone, what we call hyperandrogenism. So this can be clinical feature, like you can see male pattern hair growth on her face, what we call hirsutism, or you can see that she has a lot of acne, commonly called pimples. She can have oily skin, and then of course she can have male pattern baldness, sometimes even from the voice. So these are clinical features. Or you can have laboratory evidence when the male hormones are measured and it is found to be higher than expected for women. And so that is the second criteria. The third criteria is that when the woman has ultrasound, the ovaries appear on ultrasound as polycystic. So polycystic ovaries is a descriptive term to describe how the ovaries appear on ultrasound. And so out of these three criteria, 2 out of them qualifies the woman to be regarded as having polycystic ovary syndrome. Of course, when the 3 of them are present, it's a classical polycystic ovary syndrome. And one of the major reasons we see them in the gynecology clinic is because either they have irregular periods or they are unable to conceive. One of the underlying pathology, like I've said, is the fact that they are not ovulating regularly. And so if they are not ovulating regularly, it reduces their chances of conception. So that means that there are several months gone by and there is no ovulation. If there is no ovulation, you cannot conceive. So one of the ways we try to treat these women is to make them ovulate. That's for those who are desirous of pregnancy, provided like I have explained earlier, other pathways in the natural conception process are intact. The tubes, at least one of them must be open. The cervix must be good. The uterus must be structurally okay and functionally as well. And so it's not enough to just, okay, somebody has PCOS, she's not ovulating, and then you pay lip service to these other parts of the structure. It's a process. So if one part is not optimal, you can't get an optimal result. So that's one of the challenges actually, because most time people just say, oh, you're not ovulating, ovulation induction. They forget to check whether the tubes are open. They forget to look at the uterus on ultrasound to be sure that, okay, the womb is fine. They are not, they are not asking if there are coital difficulties. One of the things we tend to see commonly is when it is time for men to have timed intercourse, couple to have timed intercourse, some of the men develop what we call periovulatory sexual dysfunction because of the pressure that they must have intercourse on that particular day. They might not be able to achieve or even sustain an erection. And so we have people coming back to say, oh, actually, they couldn't have good intercourse around the time that they were advised to have intercourse. And so this is another thing that we need to do. You must take history to be sure that the timed intercourse that is prescribed is actually was done, as prescribed. So that being said, again, just like the first person who talked about IUI, the fact that you have done ovulation induction and you release egg, which is ovulation, does not equate to automatic pregnancy. I think we need to get this very clear that ovulation just means that egg has been released. And so there are so many other processes that this egg must go through. It must first enter the tube, which may not be possible. It may enter the tube and then it is not fertilized. Even if it is fertilized, it may not implant. And sometimes, even if it implants, it may get, there may be a miscarriage even before the next expected period. So these are aspects, and that is why, again, when you do ovulation induction and timed intercourse per cycle, you may get about 10 to 15% chance of conception in each cycle, which dictates, therefore, that it has to be done several times. Like she has done 4 times. Yeah, she can decide to do a few more, maybe 2 more, or decide to go on to, the next level. She can do intrauterine insemination. And I think people with polycystic ovary syndrome actually constitute one of the highest percentage of women having in vitro fertilization. That is to say that this particular treatment modality may not work for some people, and so they need to go up the ladder, and some of them end up needing to have IVF for them to conceive. The reverse is true, that sometimes some of them eventually also get pregnant naturally, because the simple fact that you have polycystic ovary syndrome does not mean that you cannot conceive naturally. It just implies that there will be difficulty and delay in conception. So I think that suffices for this patient.
Okay, thank you, sir. So I have high prolactin levels and I find it difficult to calculate my ovulation. Please, sir, how can I calculate my ovulation correctly?
There are two different but related questions. Prolactin is a hormone that is produced by the brain, and it's one of the it's the hormone that facilitates milk production, and it is high in women that are pregnant and women that are breastfeeding. So if you're not pregnant and you have high prolactin, which of course can be caused by several conditions, some conditions in the brain, some medication can cause high levels of prolactin, extreme stress which most people who have challenges in conception are undergoing can cause high level of prolactin, and so it can affect ovulation. And so if you have high prolactin level and you are having challenges, ovulating, which of course will reflect usually as irregular period, then it makes it difficult for you to be able to calculate your ovulation using the regular apps that are commonly used, or the common methods of the calendar methods of calculating fertile periods. And so, because one of the conditions is that you must have regular periods. So if you have a condition, so first of all, if it is determined that the prolactin is high, then we need to do evaluation to determine what is responsible for the high prolactin. So that's one thing. But what we see most of the time is people are just giving medication. So okay, you have high prolactin. Sometimes these high prolactin are not even significant. They are not. It's not up to the level to interfere with reproductive function. But because people have read online high prolactin, they are either given medication by their doctors or they self-medicate because they have probably been given, or maybe their friend have been given medication before. But it is important to determine the cause of the high prolactin, and if it is treated, if that is what is causing the irregular period, then we expect that the periods become regular because the ovulation should become regular. And so if you have regular periods, it should be easy for you to monitor your ovulation. If you have irregular periods and you are having regular intercourse, which is one of the things we encourage, um, women to do if you're trying to conceive. If you're trying to conceive, you should aim to have adequate intercourse 3 to 4 times a week, which of course equates to like having intercourse on alternate every other day. That way, you are likely to have intercourse around your ovulation. And so you don't need to carry a pen and paper to be chatting when you are ovulating. I think because whenever you ovulate, if you are aiming to have intercourse every other day, means that you're going to definitely have intercourse around your ovulation. And it's also important to say here that intercourse a few days before ovulation is more likely to lead to conception than the intercourse that happens on the actual day of ovulation, which is still better than the intercourse that is happening after ovulation. So if you want to get pregnant, you should aim to have intercourse a few days, 2, 3, 4 days before your ovulation, and you're likely to conceive. So for this patient, the prolactin levels will need to be controlled. The high levels of prolactin will need to be controlled, and then we expect that her period will be normal. Ovulation will return again, and then she can track her ovulation if she needs to have timed intercourse and conceive, or she can just have more frequent intercourse and then be able to conceive. Next one.
Okay. Um, I have PCOS and I had failed ovulation induction using Clomid and letrozole. In my first IVF cycle, just 3 eggs were retrieved and 2 fertilized. Sir, what could be the problem?
Anyway, the problem is PCOS, which we have discussed just now. Polycystic ovaries, they tend to have plenty follicles that are not releasing their eggs regularly, and they also have defective eggs. And so if you've had letrozole, clomid, and it didn't seem to work, and then you did an IVF, and the egg yield was poor, then it's important for the doctor to review, because as we have instances where because they're trying to balance between having enough eggs, not too many, not too few. So most of the time when IVF is done, the first amount of medication, that the first dose of medication usually is like best guess after the test have been run. And so if there is poor response in the first cycle, I think it will be important for the doctor to review the protocol and the dosage of medication that he or she has used for the IVF, and probably there will be better egg yield. This is also to take into consideration the age of this patient, which we are not privy to. So egg yield also declines with age, and so we do not know the age of the patient.
Another one says, I had a myomectomy done at your hospital in August of 2021. The fibroids have grown back. I had an ultrasound done in October last year, which showed that they have regrown. My question now is, will it affect my fertility?
All right. Fibroid surgeries usually a temporary measures to create a window of opportunity for women to be able to possibly conceive and to reduce symptoms after the fibroid surgery. Otherwise, the best surgery for fibroid is to take out the womb. So when we do fibroid surgeries, we always caution patients before the surgery, give them options, explain each of the available options, and let them know about recurrence. Because in the first instance, we do not know the cause of fibroid. And so when you do remove what is there, then you are unable to, you cannot tell that, okay, because you've removed what is there, other ones will not grow. So we always tell patients about the possibility of recurrence. And so if these fibroids have reoccurred, then we would need to evaluate again, scan. Fibroids that affect infertility will depend on their size, their number, and location. If fibroids are multiple and they've distorted the uterine architecture, then yes, they can affect fertility. If you have a small fibroid, just like this small one inside the womb, as small as it is, because of its location, this fibroid can affect conception. And so it can affect fertility because it will not allow implantation. So we need to see if you have this kind of fibroid, which we describe as intramural fibroid, and it is up to 4 centimeters, even though it may not necessarily be distorting the lining of the womb, it can affect fertility. So we would need to reevaluate again, look at the scan that you have done, and see whether the number of these fibroids, their location and sizes is such that it can affect your fertility. So that's what we need to do for us to be able to answer.
Okay, thank you, sir. So someone is asking, is there a cure or treatment for azoospermia?
There are two types of azoospermia. Basically, there is the obstructive azoospermia and the non-obstructive azoospermia. The non-obstructive azoospermia usually has something to do with the testis, which is like the manufacturing company. And so in that case, it may be difficult, especially if it's a congenital condition that has prevented the testis from functioning optimally. But if it's an obstructive azoospermia, meaning that the sperm is being produced, but there is blockage in the transport channel, then yes, that is amenable to certain kind of microsurgery, and then that can be cured. However, these surgeries are not as available as it sounds. And so sometimes what is done is that there are means that we can go into the testes. There are micro techniques that we can go into the testes to take out, to get this sperm during IVF. We can have what we call PISA, which is percutaneous epididymal sperm aspiration. You can have TISA, which is testicular sperm aspiration. You can have TESE, which is testicular sperm extraction. And then, of course, you can have microtest where you're actually using a surgical microscope to be able to see better, and then you can extract sperm. These methods have been used in IVF to help men who have azoospermia. Of course, azoospermia is complete absence of sperm cells in the ejaculate. And this is important because a lot of times some women misconstrue the release of semen to imply that the man is okay. And so when you ask them, has your husband done semen analysis? Oh, he's very okay, because to them, he releases semen. And so he's fine. So until you analyze the semen, you would not actually understand the amount of sperm that is contained in that semen. And so in some instances, we find that some men do not have any sperm cells at all in their ejaculate. And that is what is called azoospermia. So I hope that answers the question.
Okay, thank you, sir. Please, sir, what is the cost of failed IVF?
That's all.
That's all.
Failed IVF, there are so many causes. In fact, IVF is more likely to fail than succeed, meaning that in the best of instances, maybe you can have up to 40. If you're getting 50% per cycle of IVF treatment, that means you're doing very well. And sometimes that's where the evaluation, the IVF process is not in itself, a perfect process, because IVF can fail from the beginning. So first of all, when people come and say, okay, they want to do IVF, we need to evaluate them to determine the cause of the infertility. Because as you would see, that certain reasons why a couple is unable to conceive naturally may also be reason why IVF will not be successful, especially if this is very true when the problem is with the womb. If there are problems with the womb, and that is why IVF, natural fertility, conception is not possible, even IVF, because the same womb will need to carry the pregnancy. So if a woman has a blocked tube, if it's just blocked tubes, and so you can bypass the blocked tubes by using IVF. But if these tubes have started accumulating fluid, what we call hydrosalpinx, then that fluid is toxic to embryos, and it may be necessary for those tubes to be taken away first, to be disconnected from the body of the womb before an IVF can be successful. So there are so many reasons and so many points. Some IVF is not successful because the woman is unable to produce eggs. So we see women who are quite old. They have some of them are menopausal, some of them are approaching menopause. They haven't quite stopped bleeding, but they're approaching menopause, and they have what we call diminished ovarian reserve. Their egg reserve is already depleting, and so they want to try. So some of those women, no matter the amount, the dosage of drug you give them, they are not going to give you any egg. So IVF can fail at that point where there is no ovarian response. IVF can fail in some cases where there is ovarian response, and then you go on to collect the eggs and you don't find enough eggs at egg collection. So sometimes it's bad that you have no egg at all. We call that empty follicle syndrome. IVF can fail where you have total fertilization failure, where the sperm and the eggs are brought together. Both seem to look very okay, and then you put them together and you check the next day and you find that there is no fertilization. IVF can fail that, okay, there is fertilization, and so you are now at the stage of culturing these embryos in the laboratory to get to day 5, and majority or all of them may stop growing after 1 or 2 days. So their growth get arrested. IVF can fail at that point. And then, of course, IVF can fail that, yes, you have these embryos, and then they have grown very well. You're on day 5 now, you have the blastocyst, and then you do your transfer. This is actually where most IVF fails and is disappointing, because you do your transfer and by hope, this transfer is like you are planting seed at the time. So the embryos are the seeds, the womb is the soil, which again emphasizes the importance of the womb in IVF. And this is the part that most women tend to ignore. IVF is not magical treatment. It's a treatment that is based on rational principles. And so when it gets to the point where you are doing your embryo transfer, you can liken it to planting seeds. When it's going to be planting season, a good farmer goes to look for a good land first, prepares the land, and then he knows that, okay, this land is ready for planting, then he goes to get his good seeds. So because he knows that if he gets the best of seeds and put it in a defective soil, it's not going to germinate. So, and this is the part that is difficult for us to let women understand, that your womb, is as important as the embryos that you want to transfer onto this womb. And so if the womb is not in order, as it were, most of the money that is spent in IVF is actually spent in getting these good seeds. And so there is less attention until recently, where we are now focusing attention, and that is because there is a test that enables us to look inside the womb without having to cut, which is what we call hysteroscopy. Hysteroscopy gives us an opportunity to examine the inside of the womb without making any cut. And I think this test is very important for most women who are going to have IVF, and especially for those that have had 1 or 2 implantation failure, to undergo what we call hysteroscopy, to look inside their womb to be sure, because there are certain things inside that could be wrong with the womb that ultrasound alone will not be able to pick. And so, like I was saying, implantation failure is where most IVF fails. You have transferred these beautiful embryos to you, the womb looks okay, and then the woman is waiting for 2 weeks, taking injection and medication every day and hopeful. And then it's also like the longest part of IVF, because at this time there is no way to know whether anything is going wrong or not. You just have to wait until that 2 weeks, run your test, and then what you find, if it's negative, then you know that you've had implantation failure. So, and then of course, to cap it up, when a woman has gone for IVF, what she's looking for is a baby, is not just pregnancy. And so when we are looking at IVF failure, it does not just stop at that pregnancy test. We go beyond it. So, okay, if the woman end up with a miscarriage, it can still be considered as a failed treatment. And so, because what we're looking at, especially in our center, we pay attention to take home baby. How many women have this IVF and eventually deliver a baby? Because ultimately, that's what they are looking for. There is nothing to gain from, oh, I got pregnant, but I miscarried. I got pregnant, but nothing was seen on scan. So, everything must be put in place to ensure that, yes, if eventually the woman gets pregnant, then the pregnancy again is sustained. And so this is a holistic approach to looking at the cause of IVF failure. It's not just when you have a pregnancy test that is negative, it starts before then, it can happen before then. Yes, most of them happen at the end, like, okay, pregnancy test is negative. But even when pregnancy test is positive, you still need to be monitored closely. You need to take medication to nurture the growing fetus to be able to have a successful delivery.
Okay. Good evening, sir. I had a surgery in April 2023. I saw my period in May 2023 and it lasted for just 2 days. But this June, I didn't see my period. It's now 43 days since my last period and no period yet. I did a pregnancy test, but it's negative. What do you think is the problem?
The question is incomplete, unfortunately, because it says I have had a surgery. So we do not know what surgery. Was it uterine surgery? Was it fibroid surgery? Was it ovarian cyst surgery? Was it evacuation? So that question seemed rather incomplete. But if this is a uterine surgery done in April,
April,
April, and then there was a scanty menses in May,
May.
and then June there is no menses. It will be nice to have an ultrasound, which is usually our basic evaluation kit first and foremost, to look at the womb and look at the lining, the thickness of the womb, and then I think a hysteroscopy may be important to evaluate the interior, the cavity of this womb, to be sure that there is no damage that has happened in the course of the surgery. So I think that she needs to be evaluated, ultrasound, then hysteroscopy to assess the uterine cavity.
Okay. Sir, please, what is the cause of sperm leakage? Despite the fact that HSG shows that my both tubes are open and my husband's sperm is 85% okay.
Yes, we tend to hear this sperm leakage mostly from women that are trying to conceive. And many a times we try to encourage them that it's not usually so much of a problem. So again, I'm going to show you this model. So the way I'm holding it is the way the woman's vagina is oriented when a woman lies, for instance, on her back. And so when she has intercourse and then the sperm is deposited here, it pulls here and then and she stays like that. So if this woman stands up, for instance, then it makes sense that some sperm would leak back. It depends on the quantity that is deposited. But what is important is that is semen. What we need is sperm, and that is why for us to say that a sperm is adequate, each meal must contain a minimum of 15 million sperm cells. And so you can imagine if in an ejaculate, the man has ejaculated 2 meals or 3 meals, minimum of 15 million, that's like 30 million sperm cells that is deposited, and you need just one. So in the period that is there, many of the sperm cells would have crossed the cervix into the uterus to be able to cause fertilization, fertilize an egg. Where we have some concern is, okay, if this is something that is recurrent and the woman is concerned, then we will need to check just to ensure that the cervix is open. If the cervix is open, like I've explained, then we'll know that some of the sperm would have gone into the uterus, and so it shouldn't be a problem that the sperm is, if the sperm is liquid, and so if the man ejaculates liquid into the vagina, then it's rational for some of it to spill out of the vagina, and it's not necessarily that there is something wrong with the sperm or there is something wrong with the woman's vagina. And I'm sure many women who have conceived and have multiple babies have that experience. But of course, we hear this a lot from women who are trying to conceive, and that's because they might feel that that is the reason the sperm is not staying. That's why they are not able to conceive. If that is a serious concern, then you can also plan to have an IUI, which is intrauterine insemination, in which case the sperm can be collected, treated, and deposited right into the middle of the uterine cavity. Thank you.
Okay. Good evening, doctor. Please, can stage 4 endometriosis be cured, or do you just have to go for IVF?
Stage 4 endometriosis is the most severe form, meaning that all the pelvic structures are probably involved. There is what we call frozen pelvis. Frozen pelvis means that all the structures in the in the pelvis are just matted together, and so it causes, so that's like the most severe form of endometriosis. You have deep nodules, so it is difficult at that point to talk about cure, because even if you want to remove the ovaries, it's an extensive surgery to be able to remove the ovaries and the womb at that stage, and most of them end up with medical treatment. In that kind of situation, it will be difficult to even have access to the ovaries or to do ovarian stimulation. And such patients, even if they're going to benefit from IVF, will probably have to consider using third-party options like donor egg, for the IVF. But stage 4 is really a serious form of endometriosis, and fertility treatment in such patients is quite challenging. So, but then, of course, every case is individualized, and so you need to work with your practitioner to determine what best option. So, at that level, is really difficult because it's going to, at stage 4, it is very likely that the tubes are blocked. So, natural conception is outrightly almost impossible at that point. And so, IVF can come to the rescue depending on what structures are affected and what is available at the time.
Okay. So this is the last question for now. So it says, Sir, what's the cause of testicular cyst? Can it affect fertility, and how can it be treated?
The testing, like like the female ovaries, can develop cysts, and the urologists, like I said, are the ones that handle the male version of the meat. So they deal with the testes, they can evaluate and then determine that yes, these cysts are not cancerous, and then they can determine how, if it's cancerous and they're going to have to use a radiotherapy, for instance, of course that can destroy the healthy tissues of the testes. So if you have a testicular cyst, you need to see a urologist who will determine the type of cyst. Is it a benign cyst that can be removed? And then if it is, it can be removed surgically, and then the testes can still function normally. All right, so thank you for joining the live today. I hope we've been able to enlighten you a bit on infertility. We have increased your understanding of some of the issues that borders on fertility, and we would enjoin you to follow us on all our social media handles. Tomorrow is Father's Day, and I would use this opportunity to wish every man and women, Father's Day, because everybody will have a father, those who have husbands. So thank you for joining. Okay, I've just been told that we have 2 new questions. So I think we'll take those 2 new questions and then we'll end up.
Okay, thank you, sir. So it says, Doctor, please, can water break at 14 weeks just like that? In the hospital, they said it wasn't cervical incompetence. What could have caused such miscarriage?
The baby's water can break at any time, and then it can be, infection is one of the things that, vaginal and cervical infection, one of the things that weaken the membrane, and it can break at any time. And so when that happens, if it happens too early, the baby cannot survive at that early stage of 14 weeks. So it's considered inevitable miscarriage, and so the baby will have to come out. So mid trimester, 14 weeks is mid trimester. So it's difficult for me. I don't know what tests they have done to ascertain that it is not cervical incompetence. If they say it is not, they should be able to tell you what had caused the breakage at the time. But usually, that's when, in fact, if there is no infection, then of course you should consider cervical insufficiency as a possible cause. And then, of course, if you're having contraction or cramping before the water breaks, it may just be the part of the natural process, just like the way it happens in labor. And so, such would need to be properly evaluated. And then you may have what we call prophylactic sacrilege in your next pregnancy, because we do not want people to keep, of course, if you look at the definition of cervical insufficiency, where you're expected to have had this miscarriage 2 or 3 times before you are diagnosed of having incompetence, then nobody wants to have that kind of miscarriage before she qualifies to be regarded as such. There are tests that can be done even outside of pregnancy to determine whether the cervix is competent or incompetent. Ultrasound during pregnancy can also show whether the cervix is shortening and is at risk of incompetence. So these are evaluations that can be done before and during your next pregnancy. Okay.
Okay, thank you, sir. What is the best way to conceive having endometriosis and ovarian cysts?
Like I explained earlier, endometriosis is a very bad condition. It feeds on estrogen, and so it makes it difficult for us in the fertility arena to even want to stimulate them, because, like, you're putting petrol on fire. Yes, sometimes we do that, but it's something that we do with a lot of caution. And it is also important to say that endometriosis is a disease that has different stages. So if you have mild endometriosis, you can even still conceive naturally. So if you have regular intercourse, you can still conceive. Mild endometriosis stage 1, stage 2 means that maybe the tubes are still okay. Maybe you're just having a lot of pelvic pain. There is still a lot of opportunity to conceive naturally. You can have ovulation induction, you can have IUI, you can have IVF. So it depends on the stage. So it's not like, okay, every endometriosis is just the same. There are those who have mild stage 1, stage 2, stage 3 before it gets to stage 4, which is like the most severe form. So any of the fertility treatment is applicable to women who have endometriosis. If you have ovarian cyst alongside, we will determine the size of the cyst, and sometimes we have stimulated women who have ovarian cyst, especially if it is less than 4 centimeter. Reason being that if you, every time you do ovarian cystectomy, you are reducing the substance of the ovary, and thereby you are reducing the egg store or the ovarian reserve of that woman. So these are things you need to be able to put together. Do you go ahead and stimulate so that you can have your eggs, create your embryos, and even keep them first, and come back and tackle the endometriosis before the transfer? Or do you think because of the size of the cyst, you would have to do ovarian surgery first to remove the cyst before stimulation? These are not a very easy decision, like I have just said it. There are a lot of things we put into consideration to know what is best for individual patient. There is no one size fits all, and there's no treatment that is applicable to everybody. We try to individualize each patient and give them treatment that is suitable for them. Thank you very much. See you soon. Happy Father's Day once again. Thank you. Please follow us on all our social media to watch this video, and then, of course, be able to join us in our future social media programs. Thank you.